This is the fifth in a series of presentations on radiography of joint disorders in veterinary patients. The current presentation intent is to describe and provide examples of the most common manifestations of osteochondrosis in the horse. And by the end of the presentation, you should be able to list the sites of osteochondrosis and osseous cyst-like lesions, name which radiographic view is the most beneficial for each site in each joint, and be able to identify, describe, and diagnose osteochondrosis in horses. As you review the presentation, pay close attention to the exact location of the lesion in each joint, and really you should commit that to memory. As we talked about in the dog presentation on osteochondrosis, you need to know where to look in each joint when evaluating a patient with joint disease. Osteochondrosis affecting the tarsus is the most common manifestation in the horse. The lesion is often bilateral and can affect more than one site in the affected tarsus. This will not be seen until after 5 months of age, but it is a frequent finding in horses of any age and breed, and the finding is not always associated with clinical signs. The sites of osteochondrosis in the tarsus listed on the slide are listed in order of actual incidence. So the intermediate ridge of the tibial cochlea is the most commonly affected, followed by the ridges of the trochlear tali, of which the lateral ridge is much more likely to be affected. The proximal tubercle of the talus is an uncommon site that will be affected, and the malleoli of the tibial cochlea are also uncommon sites. And of the malleoli, the medial is more likely to be affected than the lateral. In a patient that has more than one site in the affected tarsus, the most common association is having a lesion in the intermediate ridge of the tibial cochlea and in the lateral ridge of the trochlear tali. Let's just look at this normal patient and identify where the lesions may be located. Notice that I've only included the two off-angle views, the DMPL and the DLPM, as these views can be the most beneficial when identifying these lesions. If we start with the DMPL, remember this is the kind of dorsal medial aspect of the joint. In this view, we can nicely identify the intermediate ridge of the tibial cochlea, and this more cranial aspect is where the lesion will be located. This is our lateral ridge of the trochlear tali. Lateral ridge, again, is oftentimes affected. And then this is the medial ridge of the trochlear tali. The proximal tubercle of the talus is going to be kind of superimposed in this region. And then this is the area of the lateral malleolus. And so don't confuse that lateral malleolus with the intermediate ridge of the tibial cochlea. On the DLPM view, we're looking at the dorsal medial aspect here, and the intermediate ridge of the tibial cochlea is now kind of in the middle here, and we don't usually identify the lesion on this view of the intermediate ridge. This is the medial malleolus of the tibia, and so that is an area that we might identify this lesion. Our lateral ridge of the trochlear tali is going to be more challenging to evaluate, and then we can see the medial ridge of the trochlear tali. Again, any shaded slides will be for your review later. This slide lists the radiographic findings that we might identify. When we're looking at tarsal osteochondrosis, just like any other site, we are looking for an articular or subchondral defect in the site where the lesion is located. This is our DMPL view, and in this patient, this is our intermediate ridge of the tibial cochlea, and there is a large articular or subchondral defect within that ridge, and you should compare the normal to this patient. Oftentimes, our horses do have large osteochondral fragments associated with their lesions, and adjacent to the defect in the intermediate ridge, there is this separated piece of bone that is our osteochondral fragment. Sometimes you'll hear people discuss a cleavage line being this radiolucent line that separates out the intermediate ridge from the separate osteochondral fragment. And then sometimes you'll be able to identify subchondral sclerosis, like we talked about in the dog. In the larger bones of the horse, sometimes that's more challenging to identify. And then typically they will have intracapsular or joint-related swelling. Our osteochondrosis lesions in the tarsus are up in our tarsocrural joint, and so our soft tissue swelling would really be localized to that joint, the tarsocrural joint. But in horses, the tarsocrural joint does communicate with the proximal intertarsal joint, so sometimes the swelling seems to go a bit beyond what you would think of the confines of the tarsocrural joint. Here is that same patient. This is our DMPL view. So for the intermediate ridge of the tibia, the DMPL is a very important view. This patient has a lateral view to the left of the image. We can also identify that intermediate ridge of the tibial cochlea on the lateral view. And again, at the cranial aspect, I can see that defect with that separate osteochondral fragment, just maybe not as easy as on the oblique view. On this view, however, I can see that there is probably moderate intracapsular soft tissue swelling of that tarsocrural joint. Here is a different patient where we also have a lesion of the intermediate ridge of the tibial cochlea. So on the lateral view in this patient, there is quite a bit of marked intracapsular soft tissue swelling that is really centered on that tarsocrural joint. It does extend down towards that proximal intertarsal joint. In this patient, it's a little bit challenging to see this aspect of the intermediate ridge. However, it does look like that intermediate ridge is indistinct and not normally shaped, and there is maybe an osteochondral fragment here. But the finding is much easier to see on the DMPL. So these are the two views when we're assessing the intermediate ridge of the tibial cochlea. On this view, I can much more easily see that there is a defect in the articular contour and subchondral bone of that intermediate ridge. There is likely some subchondral sclerosis surrounding that. And then I see one or maybe 2 to 3 separate osteochondral fragments. Most of the time, those fragments will be located near the defect in the intermediate ridge, but sometimes these fragments will actually start to migrate a little bit more distally within the joint. These are two different horses with examples of tarsal osteochondrosis involving the lateral ridge of the trochlear tali. And when the trochlear tali is involved, the lateral ridge is usually affected in the more mid through distal portion. Very large fragmentation of the distal aspect is much more common in heavy horses and is usually clinically significant. When I look at this patient on the left of the slide, this is our lateral ridge of the trochlear tali. In the very distal portion, there is a subtle subchondral lucency with a thin sclerotic line, but then there is a separate osteochondral fragment associated with it. So this is osteochondrosis dissecans whenever we see that osteochondral fragment. In this patient to the right of the slide, here's a more significant kind of articular contour defect and subchondral lucency in that kind of mid to distal portion of the lateral ridge, along with some subchondral sclerosis. And then there are several little osteochondral fragments and even a couple that have migrated even more distally towards that proximal intertarsal joint. Now I want you to notice that this patient to the right of the slide has an additional lesion. So as we said, you can have more than one site affected. And this patient also has a lesion of the intermediate ridge of the distal tibia here. So that intermediate ridge has a subchondral defect and at least one associated large osteochondral fragment. And then this patient does have moderate intercapsular soft tissue swelling. So be sure that you look for more than one site. And so some of these horses may also have the medial or lateral malleolus affected as well. Osteochondrosis in the stifle occurs in the femoropatellar joint and is most commonly identified as osteochondral fragmentation of the articular surface of the femoral trochlea, of which the lateral ridge is most commonly involved. The lesion is often bilateral. It does develop early in life, but is a common finding in both young and older horses. And as I said, the lateral ridge is the most common site. and it is typically the middle third of that lateral ridge. Osseous cyst-like lesions occur most commonly in the weight-bearing area of the medial femoral condyle. Very uncommonly, they may be present in the lateral femoral condyle or the proximal tibia. So let's look at those sites affected. These are the lateral and caudocranial views of the stifle in a normal horse. This is the femoral trochlea, and so we have the medial ridge, which is the ridge that is more cranially projecting and larger, and then we have the lateral ridge. Both can be affected, but like I said, the lateral ridge is most commonly affected, and then it's usually kind of in this middle third here. I didn't state, but the articular surface of the patella can also be affected, but it is quite uncommon. So the ridges are best seen on the lateral view, and then also we can do a caudolateral craniomedial oblique view, which will really highlight that lateral ridge, and I think I have an example in a patient case to show you. Femoral condyles are back here, but the medial and lateral are superimposed and more challenging to evaluate. On the caudocranial view, that's where we're going to best evaluate for the condyles and the osseous cyst-like lesion. So this is the lateral side of the stifle. The patella is located more laterally in the horse. I can also see a bit of fibula. If you remember that intercondylar eminence of the tibia in the horse, the medial side is mightier or taller, so that helps us figure out medial from lateral. So this is our medial femoral condyle, and this is the area that the osseous cyst-like lesions occur. Again, uncommonly in the lateral or the proximal tibia. And then we're not going to be able to see for the most part, the osteochondrosis of the femoral trochlear ridges on that caudocranial view. So this slide lists very similar radiographic findings for the stifle osteochondrosis when it is affecting the trochlear ridges. In this patient, this is a lateral view. This is our medial trochlear ridge, and this is our lateral trochlear ridge. And again, as with other joints and other bones that are affected, we're looking for these articular defects. And so this is a articular subchondral defect in this kind of proximal third of this lateral ridge of the trochlea. It can be challenging to identify in horses again, but sometimes you'll see subchondral sclerosis. And then oftentimes we do see osteochondral fragments, although I don't see any in this patient. And when they're present in the stifle, they typically are going to be in the cranial aspect of the stifle joint. And then remember, when we see osteochondral fragments, we will make the diagnosis of osteochondrosis dissecans. We may be able to identify femoral patellar joint swelling in the horse. And just like in the dog, the horse does have an infrapatellar fat pad, and so we can look for displacement of that from enlargement of the joint. This is a different patient here, a younger patient. We can see even more open physes. And this is a caudolateral craniomedial view. And this view is nice because it separates out the medial trochlear ridge from the lateral trochlear ridge a bit differently, so we can see those. It also will separate out the lateral from the medial femoral condyle, and so we can evaluate those nicely as well. So we're looking more at the craniolateral and the caudomedial part of the stifle in this view. So in this patient, there is some intracapsular soft tissue swelling of that femoral patellar joint. And then when I look at the kind of proximal third to middle third of this articular surface of this lateral ridge of the trochlea, there is a large kind of concave defect with subchondral defect and lucency. And this one seems to have some sclerosis in that lateral ridge. This is a different patient. This is the lateral view of a stifle in this patient. This patient actually has the lesion affecting the medial ridge of the femoral trochlea. And so this is our medial ridge here. We can see that there are several sites of subchondral lucency. Part of them are superimposed over this lateral ridge. And then associated with that subchondral lucency are some areas of articular defects, contour defects, and then probably some bits of sclerosis. And then this patient has many, many little osteochondral fragments of various sizes that are associated with this osteochondrosis dissecans of the medial trochlear ridge. This patient would be a good patient to get that caudolateral craniomedial oblique view so that we can separate out those ridges just a little bit more. In the stifle, we will also identify osseous cyst-like lesions. And again, the osseous cyst-like lesion is going to primarily affect the medial femoral condyle. Those findings we described in our kind of overview presentation, but let's go over them again. This is a very kind of cropped and magnified view of a caudocranial view of a stifle. And I can figure out where I am again by looking at this intercondylar eminence of the tibia, so the medial side is taller than the lateral side. So this is medial. And what we're looking for is an oval or circular subchondral lucency, so really kind of a geographic area of lysis that is oftentimes deep within the femoral condyle, and then it will oftentimes have a rim of subchondral sclerosis. And then when we have these actual cyst-like lesions, it's not uncommon to see an contour alteration of the articular surface of that medial condyle. So this patient has a little bit of flattening, and in fact this patient actually has a little bit of lucent channel that's communicating between that osseous cyst-like lesion and the articular surface. So that's kind of a little channel there. These patients not uncommonly do develop secondary osteoarthritis, and on the medial side here, the medial epicondyle of the femur, there are quite a bit of irregular changes of osteophytes, and although this one's a little bit more smoothly marginated, this is extra bone from an osteophyte formation on that proximal tibia. I'll take a little tangent because we didn't really talk about it in the tarsus, but the osteochondrosis lesions in the tarsus are not as commonly leading to secondary degenerative joint disease. This slide shows some variations on the osseous cyst-like lesions, and the osseous cyst-like lesions are going to be the easiest to identify on the caudocranial view. In this patient, there is a small concave articular defect with some subchondral sclerosis, so the bone is whiter in this medial condyle than in this lateral condyle. Again, I know medial because we're that taller medial tubercle of the intercondylar eminence. This patient has more of kind of a semicircular subchondral lucency with an articular defect and then some subchondral bone sclerosis. And then this patient is more like the patient on the previous slide, where it's more of an oval subchondral geographic area of lysis or lucency with some surrounding subchondral sclerosis and then mild flattening of that articular surface and probably a little channel here to the articular surface. Now, sometimes these cyst-like lucencies are even deeper in the subchondral bone, and then they won't be near enough to develop that channel. Here's an example of a patient where I gave you both the caudocranial and the lateral views. And again, the caudocranial view is going to be the most important view to identify the osseous cyst-like lesion. And in this patient, there is a large area of oval lucency in the subchondral bone, little bit of a rim of sclerosis, a little articular flattening with a channel, and then this patient does have some secondary osteophytes on the medial femoral epicondyle and the medial tibia. I want to point out on the lateral view, we can actually see this larger lesion. It is here, superimposed over both femoral condyles, but it's within this medial femoral condyle where there's a little bit of flattening and a little bit of a channel and then some subchondral sclerosis. And then this is where that caudolateral craniomedial view would be really beneficial. Finally, to finish out, the fetlock can also be affected by osteochondrosis, and when affected, it affects the sagittal ridge of the third metacarpal or metatarsal bone. And typically, this is going to be in the proximal or middle third of the ridge, so it's on the dorsal aspect. It is usually found in young horses. The radiographic findings are similar. We're going to look for an articular flattening or defect of the sagittal ridge in a very early lesion, and then as the lesion develops later, usually there is an osteochondral fragment or that nonspecific term of joint mouse that is typically near that articular defect. And then usually the metacarpophalangeal or metatarsophalangeal joint will have intracapsular soft tissue swelling. Here is an example of a horse that has this lesion. This lesion is going to be best identified on the lateral views, and even better than the lateral view is the flexed lateral view. So if we look at the kind of standard lateral view, I can see moderate intracapsular soft tissue swelling centered on that fetlock joint. And then when I look, this is the sagittal ridge right here that runs kind of on midline of the condyle of the third metacarpal and metatarsal bone, and it does project out more dorsally. It looks a little bit indistinct. This indentation is normal, so don't confuse that for a defect. So it looks a little indistinct, but what I notice is that when I do the flexed lateral view, which, again, I think we should oftentimes get this as a almost standard routine view, we can now see that there is this defect in the kind of proximal third along the dorsal aspect of that sagittal ridge, and then an associated osteochondral fragment. What I don't want you to think is that this is a sequestrum. So this is why it's so important for you to know the exact location on which bone we will find osteochondrosis. We don't want to confuse these lesions with something like a sequestrum or a fracture. So whenever you look at a joint, remember where to look for these osteochondral fragments and defects associated with osteochondrosis. This slide just lists the chapters in the two different references so that you can look for additional examples and read some more about the disorders if you'd like.